A very good morning, ladies and gentlemen. Thank you so much for joining us once again. It is a Saturday morning and we are here on the next installment of the SK Dharmalingam lecture series, the 24th of its kind. And this week, as usual, we've got a very interesting and eminent physician who's joining us to give us updates in the management of gastric cancer. For those who are joining us perhaps for the first time, this is a long-running series on education and awareness to our healthcare professional colleagues all across the country and the region on cancer, and this is brought to you by the National Cancer Society of Malaysia. This morning, I'm very privileged and honored to be able to have with us Dr. Abel Zachariah, Consultant Clinical Oncologist at Pantai Hospital, Keroh. Doc, good morning. Thank you for joining us this morning.
Morning. Thank you, Dr. Murray.
Oh, such a pleasure to have you with us today. And how have things been on your end since we've kind of come back from the COVID pandemic? Have things grown as busy for you as well?
Yeah, it's not grown certainly. I think COVID has put a bit of a spanner in the works. It's sort of a cost of an issue. But patients are coming back, I think. People are more confident. And yeah, but I don't think the levels are quite the same as they were pre-COVID. They haven't got quite there yet.
Right. Absolutely, Doc. And for those kind of joining us this morning, just to introduce Dr. Abel as well, and also to kind of share with you that Dr. Abel is a consultant clinical oncologist in Pantai Hospital, Keroh in Malacca. So doctor is coming to us from down south. Doc, so just a couple of questions to kind of start up and before we swing into the topic. And so how come clinical oncology? How did you end up coming into this?
I always found cancer to be quite an interesting topic, particularly when I was sort of in my late teens, because my grandmother had cancer. So then, I suppose as any teen would do, I presume when something happens, when something like that happens in the family, you sort of question why, well, what is cancer? How did this come about? Why did my grandmother have it? So started reading about a lot about cancer, and that sort of spurred my interest in oncology. And then when I went to medical school, I pursued that further, and I more or less made up my mind I was going to specialize in oncology, and specifically clinical oncology, because it allows us the breadth of being able to use both radiotherapy and systemic treatment therapy for all patients. Whereas because in the UK, when we specialize, we can either choose medical oncology or clinical oncology. And in other parts of the world, or many other parts of the world, they would specialize in either medical or radiation oncology. Whereas in the UK, much like Malaysia, the master's program, you can do clinical oncology, you can do both systemic and practice both options of systemic therapy as well as radiotherapy. So that's what, and I like physics to some extent as well. So I thought it was quite interesting. So radiotherapy involves a lot of physics, and that also contribute to my eventual decision of taking up clinical oncology.
Lovely, Doc. And of course, the other question, like kind of important, is how come Malacca is the Nyonya food really as good? Are you from Malacca originally? Anyway, sorry.
No, I'm not. My wife is originally from Malacca.
Okay.
From
okay, lovely, Doc. And you've been with Pantai Hospital in Malacca for how long now?
Just over a year. I came here last year, May. So I joined last year. So just over a year, 3 months.
Lovely. Okay. So, Doc, and then so this kind of installment, we're focusing a little bit on gastric cancer because it's kind of spilling into the month of awareness about stomach and GI cancers as well. And it's not often a topic we talk about. We're usually kind of concentrating on the top 5 cancers, of which colorectal cancer is perhaps the most sexy, famous counterpart, and sometimes gastric cancers take a back seat. So in terms of the cases that you see, Doc, are there a lot of gastric cancer cases in Malaysia today? Does it seem to be rising? Is it different than the UK?
Yeah, sure. So in UK, yes, we do come across gastric cancers for certain because we do have established MDTs there. So we discussed stomach cancers as part of what we call the upper GI and the table. But since being in Malaysia, I haven't seen many gastric cancer patients, only a few actually. And most of the patients I've seen, as you said rightly, so it would be colorectal and breast, and even head and neck cancer patients. So I haven't seen many stomach cancer patients here whilst being in Malaysia. So that reflects the trend globally as well, I guess, because you'll see my talk soon that overall, thankfully, number of gastric cancer cases are actually coming down, certainly coming down. But there's a shift in the distribution of cancers along the stomach. So the increasing number of cases where they have proximal cancer, proximal gastric cancers as opposed to distal cancers. But overall incidence is coming down. That's good news. But it's not particularly good news for patients who've got locally advanced gastric cancer. But although there are treatment options available, it's still a significant disease, and it's a major cause of mortality from cancer worldwide. So a patient with colorectal cancer or breast cancer, in terms of survival, stage 4 stage is probably going to do, unfortunately, better than gastric cancers.
Right.
And there are reasons for that biologically, because of the behavior, it does have a more aggressive behavior, generally speaking.
Right. Absolutely, Doc. And today, really, Doc's here to kind of shed light for us on this rare dinosaur that we don't often talk about or deal with, and perhaps to give us a little bit more awareness, and for colleagues who are in primary care medicine, kind of to keep an eye out for those funny things that may turn out to be gastric cancer within our patients. Without further ado, please allow me to turn the session over to Dr. Abel, and right after, as usual, we can take some questions right at the end of this. Doc, over to you.
So thank you again, Dr. Murali. Just share my screen. So once again, thank you to NCSM for inviting me to share this topic with all of you. And thanks for joining us today. We're going to talk about gastric cancer. I'll do the best I can to give you a sort of like a run through about gastric cancers. And in particular, I'll be focusing more in terms of for gastric adenocarcinomas for non-cardia gastric cancers as opposed to cancers that arise within the cardia or the esophageal junction. Esophageal gastric junction. So this is the anatomy of stomach, a simple anatomy diagram demonstrating the esophagus, the fundus of the stomach, the body of the stomach, the pyloric regions of the stomach, which includes the pyloric antrum, the pyloric canal, and the pyloric sphincter. And the cardia is the region that's very close to the gastroesophageal junction. So for purposes of discussion today, we're going to be focusing more about gastric cancers that arise beyond the cardia, or the antrum and the pyloric canal. So as I was mentioning earlier, the good news is the rates are declining worldwide as well as in Malaysia. So for example, in 2003, the age standardized ratio for 100,000 people is about 13.3 amongst males in Malaysia, but in 2016 it dropped to about 6.9. In females, the risk is much lower compared to males. And again, it's also dropped from 6.8 to 4.7 in 2016. So one of the main reasons for this worldwide is because of the advent of the refrigerator. Because now we don't have to preserve our food anymore in salt. And there is a link between high intakes of salted food, preserved salted food, and foods that contain a lot of nitrosyl compounds with the incidence of gastric cancer. And we believe that the reason why the incidence globally is dropping is because of the advent of the refrigerator. So where would we be without the refrigerator? It's something that we take for granted. We have it in our house, or all houses that I know of that I've visited. Everyone would have a refrigerator. There are parts in the world that don't have a refrigerator, and but we're fortunate that we have this simple invention that's been around for some time, and it's certainly brought about a difference in all our lives. So let's look at epidemiology of gastric cancers, particularly in Malaysia. And the incidence, interestingly, is highest amongst the Chinese group, and it's lowest amongst the Malays. However, the overall incidence is decreasing and amongst the Chinese, but it's increasing slightly amongst the Malays. And males are 2 times more likely than females, as demonstrated earlier by the table I showed earlier, and tends to happen in men who are above the age of 50. In Asia, Southeast Asia in particular has a lower incidence than East Asia and Orient. In fact, East Asia, Japan, Korea, Taiwan, they tend to have the highest in the world. There are also regional differences within Malaysia itself. And interestingly, I was reading earlier, the Malays in Kelantan perhaps have the lowest lower incidences than Malays in Penang, and they may actually have one of the lowest incidences of gastric cancers in the world. It may be down to biology or the dietary factors in Kelantan itself, or maybe even the pickup rates, or or whether we actually pick up stomach cancers in the early stages in Kelantan. So there are other independent risk factors for gastric cancer. I think it'd be quite useful to run through this. Low levels of medication with odds ratio of 9.8. Is primarily linked with increased incidence of gastric cancer, and there are various other issues related to that might be a contributing cause. High intake of salted fish and vegetables, as I mentioned earlier, that's globally that the need to preserve food has dwindled significantly because since the advent of the refrigerator. But places where there's a high intake of salted fish and vegetables, the odds ratio is about 5.2. So that is strongly linked with the gastric cancers. H. pylori infection, we're all familiar with, is a known risk factor for gastric adenocarcinoma with an odds ratio of 2.5. Smoking is also related and linked with gastric cancer incidence with an odds ratio of 2.5. But the high intake of fresh fruits and vegetables is an independent protective factor. And this is something that has been looked into and has some proof that it can be protective with regards to preventing the development of gastric cancer. The highest independent risk factor in Malaysia itself is the ethnicity. So being Chinese, their odds ratio is about 10.23. Why that's the case, we're still uncertain. It may be to do with the H. pylori behind, or the strain of H. pylori that's seen in Chinese patients compared to, for example, the Indians, who also, although they may have H. pylori infection, but the strain of H. pylori that's seen in Indians may be a cause as to why there's a lower incidence of gastric cancer among Indians than perhaps even Malays as compared to the Chinese. That's a subject of discussion and even research. Yeah, that's something that's been noted, interestingly. The prevalence of H. pylori is based on serology is high in patients with gastric cancer is quite high. So if you do a serological test for H. pylori, it can be positive in more than 70% of patients, even if they have a negative H. pylori test with a urease-based test. Diversity of H. pylori strains, as I mentioned earlier, may explain partly the incidence of gastric cancer in Chinese. And we know that H. pylori is the commonest cause of gastritis, which is a precursor condition before the development of gastric adenocarcinoma. And H. pylori has been recognized by the WHO as a class 1 carcinogen. Smoking, as I mentioned earlier, is a risk factor, and there's actually some evidence, meta-analysis of several studies that have shown that the risk was increased approximately 1.534 and more so in men. Interestingly, the EBV virus, that's the VAR virus, may actually account for 5 to 10% of gastric cancers. It's not something that's recognized regularly. We are aware that EBV is strongly associated with nasopharyngeal cancers, but we know that in Malaysia that's really the case. But apparently, this virus can also account for quite a number of gastric cancer cases. They tend to present with a distinct clinical pathological characteristics. It's more likely to happen in men. The location is more in the gastric cardia. It's associated with predominantly high lymphocytic infiltrate. And the good news is it's got a lower frequency of metastases and it's usually associated with a diffuse histology. There are other risk factors as well, including true hereditary gastric cancers. Familial gastric cancers in general may account for up to 1 to 3% of the global burden of gastric cancer. So it's not common. The 3 major syndromes that have been recognized include the hereditary diffuse gastric cancer, gastric adenocarcinoma, proximal polyposis of the stomach, and familial intestinal gastric cancers. For the purpose of discussion, I won't go into details about hereditary cancers at this moment in time. To talk about other risk factors, for example, the precursor lesions that I mentioned earlier, So one of the things that we learned in medical school and still holds true today is that chronic gastritis in the stomach, be it caused by H. pylori or any other agents, can then go on to develop chronic atrophic gastritis. Then that leads on to intestinal metaplasia, which then goes on to develop dysplasia, and eventually that's a precursor for the development of intestinal adenocarcinoma. So it's a multi-step process, and along the steps, there are additional mutations that take place at the DNA level, which can then lead to the development of full-blown cancer. Staging of gastric cancer is one of the oldest staging systems, where you've got the T system, which looks into the depth of the cancer itself, the primary cancer within the stomach, T1, T4, lymph node stagings, including local regional lymph nodes around the stomach, around the spleen, etc. And the M staging, which describes the presence of metastasis and all. So the TNM staging is still obviously widely used for gastric cancers, but if there were patients out there who listening to the talk, it's something that you may come across with in your discussions with your oncologist or your surgeon. Sadly, though, most patients in Malaysia do present with stage 4 and 1 disease. In countries where there's a good or established gastric screening programs, like in Japan, quite a number of patients present with early gastric cancer, and I'll talk about this later. So location of tumor within the stomach itself, as I mentioned earlier, there's a lower incidence of gastric cancers nowadays compared to before. But most patients in the past used to present with tumors that were located more distally in the stomach, i.e. in the pylorus or the body of the stomach itself. Most patients in locally reported cities in Malaysia had tumors in the distal region of the stomach, as you would expect. But the change of distribution of cancers from the body and to the stomach, to the more proximal areas, for example, the cardia and the fundus, has happened more or less during the past 20 years. The exact reason as to why there's a change in distribution is a bit unclear. Maybe to do with the increasing incidence of gastric esophageal reflux disease, or it's partly related to that. And the worrying thing, though, although the incidence is coming down, but the proximal lesions, if they were to patients with proximal lesions, the cancers tend to be a bit more aggressive, and they carry a worse prognosis stage for stage compared to distal gastric cancers. Special mention about the esophageal gastric junction cancers. As I mentioned earlier, I talked more on cancers beyond the distal to the cardia. But in the latest TNM edition, the 8th edition, esophageal gastric cancer tumors with the epicenter that's less than 2 centimeters on the proximal stomach could be classed as a primary esophageal junction cancer. But the epicenter of the tumor is more than 2 centimeters into the proximal stomach, that is classed as a primary stomach cancer. And determining the epicenter will depend more on the radiologist's expertise as well as the endoscopy findings of the gastroenterologist or the surgeon. Now, early gastric cancer, as I mentioned earlier, is a concept that's first originated in Japan. It was defined as a cancer that can be treated successfully with surgery. Now it's defined more precisely as an adenocarcinoma that is restricted to the mucosa or submucosa, irrespective of lymph node metastases, if you will, as T1 disease. These cancers have significantly better prognosis, approaching 90% 5-year survival rates. And early gastric cancers, as mentioned earlier again, are more likely to be picked up in countries with high incidence of where a population-based screening program is available. So that brings me to gastric cancer screening. So universal or population-based screening is implemented in some countries with a high incidence of gastric cancers. And in Japan, as an example, I mentioned earlier, screening for gastric cancer is recommended for individuals over the age of 50. It usually be double contrast Bayesian radiograph with photofluorography every year, or an upper endoscopy every 2 to 3 years. Upper endoscopy is also recommended every 2 years for individuals aged 40 to 75 in Korea. In countries with low incidence of screening should be directed for specific high-risk subgroups, which would make sense. It's more cost-effective, particularly for patients who already are known to have, say, for example, gastric adenomas, which are benign polypoid lesions rising within the gastric, within the stomach. Patients with a history of pernicious anemia, they also can end up having chronic atrophic gastritis, and therefore that will be a precursor lesion for gastric cancers. Patients already known to have gastric intestinal metaplasia. familial adenomatosis lupus polyposis is another familiar condition where patients have multiple polyps along the GI tract, and they are also at risk of developing stomach cancers, other than colorectal cancers, and even small bowel tumors. Patients with Lynch syndrome, tend to have a high risk of developing a colorectal cancer, but they can also develop stomach cancers. Peutz-Jeghers syndrome is another condition as well associated with stomach cancer, and these patients typically have sort of papular lesions around their lips, pigmented papular lesions on the lips, and juvenile polyposis syndrome is another group of patients where they are high risk of stomach cancers, and probably should enroll themselves into a formal screening program. Gastric cancer classification, we've got histological classification, we've got macroscopic classification as well as a more recognized classification nowadays, or increasingly recognized, what we call a molecular classification. So histological classification, some differences exist in gastric histology interpretation between the East Asian and the Western pathologists, and therefore the difference in interpretation may lead to a higher proportion of early gastric cancers being diagnosed in East Asia. For example, in the West, the pathologists will describe invasive cancer once the cancer invades the lamina propria. Whereas in Japan, if I'm not mistaken, the pathologists would not just classify a cancer based on whether it invades lamina propria. The cytology, the atypical cytology, and the architecture of the cancer itself would suffice for pathologists to find cancer, and therefore these patients may have intramucosal carcinomas, and would therefore be termed to have early gastric cancers, and therefore subject to endoscopic resections of the tumors. There's also the Lauren classification, which is what we're all quite familiar with, and it's been used for many years, where we divide the histology to two different subtypes of gastric adenocarcinomas: the intestinal subtypes, where you have the well, moderately or poorly differentiated cancer, or the diffuse, which tends to cause a poor prognosis. We describe it as undifferentiated with or without significant cells. Macroscopic classification, there are various macroscopic classifications that exist. One of the common ones that we tend to use is the Borman system. This system has also been incorporated in the Japanese gastroenterological endoscopic classification as well, describing the early polypoid or ulcerating lesions as part of the early gastric cancer classification. So for Taiwan, we tend to see a polypoid mass, and type it's fungating and ulcerating. Type 3 is the progression of the ulcerating, where it starts to get infiltrative, and type 4 when it's more diffuse along the stomach wall and semi-infiltrate. In the molecular classification, for example, the NIH Cancer Genome Atlas project has suggested 4 subtypes. We would describe them. The 4 subtypes include the genomically stable tumors, and they tend to have a diffuse histology, tumors with chromosomal instability, or otherwise known as CSI, and they tend to be seen in patients with intestinal histology. Epstein-Barr virus, I alluded to earlier, so that's also has formed a subtype for stomach cancers. Also, the Epstein-Barr virus positive subtype with marked DNA hypermethylation, and microsatellite unstable tumors, or microsatellite high, with elevated mutation rates. The intestinal and diffuse subtypes are the major subtypes, and whereas the UBB and the MSI subtypes account for about 10% each of gastric cancer. The classification for early gastric cancers, there are systems that have been developed for that as well, but it's rarely used in the US or in Europe. So the Japanese have been a pioneer in this, and they have their macroscopic classification, superficial gastric carcinoma, widely used in East Asia, and it's based predominantly on visual and endosonographic features. So we move on to surgery, and this is the primary treatment modality at this moment in time for gastric cancers, or even minimal surgery, including endoscopic resections for early gastric cancers. I won't focus much on early gastric cancer today, talk more about gastric cancer a little bit more advanced than that. But suffice to say that complete surgical removal of gastric cancer, along with reducing lymph nodes, offers the best chance of survival survival at this moment in time. So therefore, defining what is resectable and what is unresectable is very important, because that fine line could be tested in different MBTs. So there may be some MBTs, or depending on expertise of the surgeon interesting, might suggest that a particular patient with a particular tumor may have an unresectable disease, but but if the same case was discussed in a center where there's a high volume of cases by an experienced surgeon, they might define the resectability slightly differently, or unresectability slightly differently. But suffice to say, the consensus will be that unresectability will define the presence of metastatic disease, and or if the primary tumor invades the major blood vessel, for example, the aorta. Local regional nodal involvement also in itself does not define unresectability unless the nodes are further away from the first to second or occurring sites being involved. For example, that which is behind the inferior pancreas, the aortic region itself, the mediastinum, or portagetes, as these are usually outside of the standard surgical field. So that would also define unresectability. Looking at the regional lymph nodes of the stomach, we've got the pericardial nodes, the perigastric nodes along the lesser curvature, the perigastric nodes along distal curvature, and that of the proximal greater curvature or pyloric, as well as the nodes that sit in the celiac axis, including celiac nodes, left gastric nodes, sphenohylian nodes, and the hepatoduodenal regional nodes. So these would be classed as local regional lymph nodes of the stomach. So surgery, there is total versus partial gastrectomy. These are the two main modalities of surgery that we employ. Now, I'm not a surgeon, so I'm certainly not an expert in the surgical modalities for stomach cancers, but this is just a sort of a brief overview of the options available. So total is usually reserved nowadays for proximal third cancers, and partial or subtotal gastrectomy for the distal two-thirds cancers. As more and more patients are developing proximal third cancers, total gastrectomies are more or less the standard of care for a number of these patients these days. And the reason why total will be preferred to partial for proximal third cancers, if I'm not mistaken, is because the incidence of gastric reflux is quite significant. They had partial or subtotal gastrectomies, and they usually do better, and the quality of life is better if they had a total gastrectomy. There's a photograph of gastrectomy with a general anastomosis, where the stomach is removed and the renal stump is left in situ, and the jejunum is then brought up and anastomosed with the distal esophagus, and the renal stump is then connected with the distal jejunum to ensure that the pancreatic secretion still has a role to play in the normal physiology, and re-enters the distal jejunum. So for surgery and lymph node dissection, for patients with T2 and above, they will require a lymph node dissection. So you can't just do a gastrectomy unless it's a palliative procedure where the patient has significant metastasis or there's acute bleed and the patient is in extremis. But apart from in an emergency setting, in an elective setting, they have to have a lymph node dissection. Major cancer centers would offer a D2 resection, or something what we call a D1 plus, a modified D1 resection. And NCCN would recommend, the National Comprehensive Cancer Network guidelines recommend a regional, a D1 or at least a D2 resection, and the D1 involves regional lymphatics. For example, the perigastric nodes I showed earlier along the curvatures of the stomach, those along the left gastric artery, common hepatic artery, celiac artery, sphenohylian artery would mean a D2 resection. So the regional nodes mentioned earlier. So they recommend at least a D2 resection. And in particular, one of the aims for that is to make sure there's at least 15 lymph nodes in the harvest. So these are examples of the different forms of gastrectomies available, the total and distal gastrectomies, or even a proximal gastrectomy. And the various stations of lymph nodes have been described very well, particularly by the Japanese Gastric Cancer Association. So a D1 resection, for example, will involve the perigastric nodes, for example, with positions 1, 2, 3, 5, and 6, whereas the D1 plus will involve taking out some of the lymph nodes around close to the pancreas, 8A, 9, 11P. And then those who have D2 sections, you have station 12 and 11P and 10 as well. So ideally, you want a D2 section alongside the gastrectomy. So D2 resection, while preserving the spleen and pancreas, offers a superior staging. That's why they recommend it, and it may offer an additional survival benefit compared to D1 resection alone, at least a suggestion of an improved disease-free survival. D2 resection, which is done in some centers, particularly if I'm not mistaken, in East Asia, which involves a paralytic lymphadenectomy. That's not routinely recommended, and it does not appear to add survival benefit and may in fact increase perioperative mortality. So trial evidence for a D1 resection versus D2 resection. The MRC trial, which included about 400 patients approximately, patients had either D1 or D2 lymphadenectomy, and it's noted that the postoperative mobility was greater in the D2 group, as 46% was 28%, and operative mortality was also greater at 10%, almost twice that of the patients who had D1 resection. One of the reasons for this may be because of the liberal use of splenectomy and distal pancreatectomy to achieve complete nodal resection. If you remember earlier, as I showed the lymph node stations were very close to the pancreas. So in order to achieve adequate D2 resection, some surgeons were actually removing the distal pancreas or the spleen so that they can remove the D2 nodes. Other nodes they'll classified as D2 for D2 resection. So to achieve that, if they did this, that would be associated with increased mobility and mortality, as you can imagine. However, interestingly, the overall survival, despite the doubling of mortality rate, was similar in both groups, which implies that with D2 resection, there's also lower recurrence rates for the patients who survive, which then lends on to improved survival, which then leads to almost an equal survival for those who had D1 versus D2 resection. Dutch gastric cancer group trial included approximately about 700 plus patients, also demonstrated that increased postoperative mobility and mortality high in the D2 group. If I'm not mistaken, in the Dutch gastric cancer group trial, they actually had a Japanese surgeon, relative surgeon, also be part of their quality control, was involved in the trial as well to ensure that they had local expertise available locally to perform the procedures. Despite that, the overall survival is similar with long-term follow-up, but the curves continue to separate for those who've had D1 versus D2. And again, this is probably related to a lower recurrence rates and lower gastric cancer rates in the D2 group, despite the increasing morbidity and mortality in the D2 group. The Cochrane analysis or meta-analysis also showed a significant disease-specific survival advantage in D2 resection, despite the higher postoperative mortality in D2 resection. So the gist is, if possible, where it's available, and certainly recommended, D2 should have a D2 resection if it can be done without the increase in operative mortality. Hence the reason why we should consider offering patients stomach cancer surgery with D2 resection in centers of not just excellence, but centers where there's a very well-established MDT and you've got a high volume of cases. So to ensure that your operative mortality rates are low enough to justify doing a D2 resection, so to ensure the patients get tested. The trial evidence for the D2 versus the more extensive D3 resection, again, is a Japanese trial, approximately 500 plus patients. We compared patients with D2 versus D3, and in this trial, despite having a D3 resection, there was no increase in operative mortality in D2 and D3. Similar recurrence, however, did show a similar recurrence free in overall survival in both groups, and in the 2015 Cochrane analysis, there's no survival benefit. So we will not recommend doing a D3 resection beyond D2 resection. Let's talk about the field, the modalities of treatment that I'm particularly familiar with, which is the neoadjuvant and adjuvant treatments that we offer for stomach cancers. Potentially resectable non-cardiac, as I mentioned earlier, we're talking about cancers beyond the cardia of the stomach. For non-cardiac resectable, so they are resectable cancers, not cancers that are unresectable at the very start, at the upfront. These patients can have surgery. The randomized trials for these patients and meta-analysis have shown a significant survival benefit for surgery alone for several approaches. And they can be divided into adjuvant chemotherapy, that's using intergroup 0116 trial in America, CalGB 0101 trial. Perioperative chemotherapy group, where patients have received both preoperative and postoperative chemotherapy, as demonstrated in MAGIC and the FROG trials. And adjuvant chemotherapy alone, used often in East Asia, in Korea and Japan. This is the NCCN guideline snapshot for patients who had local regional disease, where if it's a potentially resectable T1B disease, they would tend to go for surgery directly, but C2 or higher any lymph involvement, even if it's resectable, it would still suggest, as according to NCCN, preoperative chemotherapy or indeed preoperative chemoradiation, but that's more for the EGJ tumors, and I'll discuss that a bit later. Obviously, if the patient is medically fit but surgically unresectable, we need to consider chemoradiation or systemic imaging up front, and I'll discuss that briefly again later. So for most patients with resectable non-cardiac gastric adenocarcinomas, combined modality approach would be preferred. So not just a stomach cancer, not just the gastrectomy plus T2 resection alone. We would suggest a neoadjuvant approach first rather than adjuvant therapy, particularly for those at risk of developing metastatic disease, i.e. those with bulky T3, T4 disease, or with evidence of nodal involvement. So staging of the patient prior to offering anything is of vital importance. It's not just the radiological evidence for CT scan, but endoscopic features, and in some centers they even do a laparoscopic assessment, particularly when the radiology features are equivocal. And in some centers, it's standard procedure for surgeons to do a laparoscopic procedure to assess whether the tumor is indeed resectable or not. And sometimes you might, a surgeon may find evidence of disease that's beyond the stomach, which was not really picked up or was failed to be picked up on a routine CT scan. So the rationale for giving a neoadjuvant treatment is better chance of delivering chemotherapy schedule preoperatively. For example, there's no wound issue or less wound issues, and there won't be we wouldn't have to deal with a patient who may have a significant postoperative complication. As I noted earlier, with the T2 resection, there are in some centers some patients do have a higher morbidity and mortality rate. So maybe it's clinically and more sensible to try and offer a patient preoperative chemotherapy. And the rationale that can be or may spare patients from unnecessary gastrectomy if they were unfortunate enough to develop distant metastases during or after the chemotherapy schedule. If they develop during the chemotherapy schedule, then they got primary resistance to chemotherapy and they tend to do poorly. But at least you would spare them from having an unnecessary and significant gastrectomy. So neoadjuvant treatment as a first modality, there are different chemotherapy regimes available. The regime that we tend to use nowadays for medically fit patients with a very low performance status and tend to be younger groups, younger patients with minimal morbidity is the FROG regime, where we give docetaxel, oxaliplatin, leucovorin, or uracil. That are more traditional chemotherapy regimes that we used in the past. We can put ECFG, it's used in the MAGIC trial or the ECX equivalent, or indeed an oxaliplatin-based treatment, for example, KFOX or FOLFOX. Again, the fitness of the patient and the performance status of the patient in extent of disease would help us determine which is the best regime for the patient until and when we've seen them in the clinic to assess their preference and the risk-benefit ratio. So this is the UK Medical Research Council MAGIC trial. It's quite a famous trial. It had, if I'm not mistaken, it was in the early 2000s. And it was a practice-changing trial as it showed that patients with resectable cancer, the road to the esophagus, cerebral junction, and stomach who had perioperative chemotherapy, they had a better survival than those who had surgery alone. And this trial more or less shaped the practice for us oncologists in the UK. And we used to offer patients perioperative chemotherapy quite often for resectable cancers in the clinic. And the practice of either preoperative chemotherapy or postoperative chemotherapy, interesting in the UK and in fact in a lot of parts of Europe, it's not really a practice that's commonly used. It tends to be used more often in the US. So we would offer 3 cycles of ECF before and after surgery, and only 42% of patients will complete the protocol. As you imagine, that a lot of them struggle to complete the 3 more cycles of chemotherapy after surgery. But despite that, there's still a significant overall survival benefit given chemotherapy, which I'll argue probably been driven predominantly by the pre-operative chemotherapy. The benefit was probably driven more so by the 3 cycles of chemotherapy the patients had before surgery. The Prodigy trial involving all interventions, we had 480 Korean patients in the trial, and they had neoadjuvant chemotherapy followed by gastrectomy and B2 resection, which is mandated, and they had adjuvant S1, which is adjuvant treatment that's available in Malaysia and obviously in East Asia, and they have it for 48 weeks. Interesting to know, S1, as far as I'm aware, is not available in the UK. It's certainly not available in the US. Versus gastrectomy and B2 resection and adjuvant S1 for 48 weeks. So it's neoadjuvant chemo followed by adjuvant chemo after gastrectomy versus gastrectomy and adjuvant chemo alone. And the addition of that neoadjuvant chemo improved the TV3 progression-free survival additional 60%. So neoadjuvant chemo radiation is certainly not recommended for non-cardiac gastric cancers, but higher up the cancer is along the EGA and the carcinomas, for example, and the POET trial. It is certainly a modality treatment that can be considered, and the trial which showed some meaningful survival benefit, failing chemotherapy by its upper borderline significance. In the neo-AGES trial, outcomes in favor of chemotherapy, but again, survival difference was not significant. There are currently ongoing trials to establish the role of neoadjuvant chemotherapy for non-cardiac cancers. What happens if you have a poor responder? So what's interesting about offering neoadjuvant chemotherapy to patients with stomach cancer is that you'd obviously expect or hope to see some form of pathological response to the chemotherapy once they've had surgery. Patients who've had pathological complete response means they have a complete response pathology. We don't see any evidence of cancer, and that doesn't happen very often. But if that happens, then patients tend to have a much better prognosis, as you imagine. But there are patients who are poor responders that, despite having chemotherapy, they don't seem to show much downstaging effects. Regardless of whatever perioperative chemo regime you use, the analysis of cohort studies would suggest that still best to complete scheduled post-operative chemotherapy component, even if there was a poor pathological response to the same treatment given pre-operatively. For example, by giving ECF chemotherapy to patient 3 cycles like the MAGIC trial, private stomach cancers, even if the response is poor and it's still positive nodal disease, for example, I would still want to complete the post-operative course as long as the patient is able to comply and able to undergo the treatment. In the critics trial, the Dutch critics trial sample, there was approximately 780 patients who had induction chemotherapy, followed by gastrectomy, followed by PGDipCR or chemoradiotherapy. And there was no significant difference in survival. So some of these patients would have no positive disease, and some of them would obviously be randomized to the same chemotherapy, but despite that, apparently there's no significant difference in survival, even if you were to escalate treatment, or if you were to upgrade the treatment, if you will, to offering adjuvant chemotherapy to patients with disease. So surgery, if surgery was done initially, so you've not had an opportunity to discuss MBT, or if it was discussed MBT and it's patient preference and the patients ended up having surgery up front, if a curative surgery is done without having had to receive primary therapy, she obviously should receive adjuvant treatment, i.e. those with M1 positive disease, perigastric region, for example, and for T3, sorry, so the title there is T3 or T4 cancer disease. Options should include chemotherapy plus chemo and chemo alone. Generally speaking, if a D1 section is done, then the trend will be to offer, or will be more inclined to offering chemoradiotherapy and chemotherapy, and that would seem reasonable because they've had a less than optimal surgery, if you will. If a D2 resection is done, excuse me, even if there's no positive disease, chemotherapy alone will be adequate. So for adjuvant chemotherapy, there are numerous trials, excuse me, but mostly negative results when overall survival is used as an endpoint. Now, in the adjuvant chemotherapy trials, the quality trials have come to question, and some of them were underpowered to detect the difference, and some trials And a meta-analysis of all these trials, however, support survival benefit. And interestingly, and we've noted this historically as well, and this is the case even now, that prognosis appears to be better for patients from East Asia. And it's not just because of early of them being diagnosed with early gastric cancers, even the stage for stage, they appear to do better than patients from the West. In the classic trial, involving 1,000 over patients, the Korean trial, where K-pox chemotherapy is stimulating the surgery alone for stage 2 to 3 disease. It showed an improved disease-free and overall survival. And although this K-pox or 4-pox would be a reasonable alternative, that's oxaliplatin and 5-FU or appropriate-based treatment. And K-pox is oxaliplatin plus cytidine oral chemotherapy. Oxaliplatin is intravenous infusion. The XGC trial, again, is a Japanese trial with just over 1,000 patients and used S1 chemotherapy as a monotherapy for a year and showed a significant survival benefit compared to surgery alone. Both classic and XGC trials have shown that survival for these patients, even with surgery alone, are better than the European cohort. So if you look at the standard arm, that surgery alone, survival is much better than what we described. For example, the MAGIC trial. And the MAGIC trial, those who had surgery alone for 5 years, survival rate of 73% versus 61% in the XGC trial, which is an interesting point to note. Highlighting the fact that I mentioned earlier that patients in East Asia tend to be better prognostically. In the JACO GC07 trial, the addition of docetaxel to S1 improves the survival further for at least for the patients with stage 3 disease. So going back to adjuvant chemotherapy, it's stable for patients who have not undergone a deep resection, or which is more possible, more likely reason is if they have a R1 or R2 resection. So an R1 means a microscopic positive margin, and R2 means a macroscopic positive margin, i.e. you know, or the surgeon is aware that he or she has left some cancer behind. So if they've got macroscopic disease or microscopic resection margins that are positive, even if they've undergone a deep resection, we would probably favor adjuvant chemotherapy more so, simply because an R1 or R2 resection margin that's positive would indicate a much higher risk for local regional recurrence. And we don't think that adjuvant chemotherapy so that would suffice to reduce that risk. The INT-1106 trial showed a significant overall survival benefit of chemoradiation post-surgery. Interestingly, the distant metastatic rates are similar, but the local regional recurrence much less in which is what you would expect. You would expect lower local regional recurrence if a patient had chemotherapy. However, in the control surgery alone arm, it's important to know that only 10% of patients had P2 resection, although it was in the trial protocol. Only 10% of patients actually had P2 resection, and 54% of them did not even have a T1 clearance. So, and that would probably explain the higher relapse rates seen in surgical near. So therefore, the argument or the critics of the trial suggests that the reason why patients who had chemotherapy did much better is because it compensated for poorer surgery. So whenever you look at trials, it's always important to scrutinize the standard arm, because your comparative, sometimes the validity of the trial, the results of the trial, the difference is sometimes dependent on how good your standard arm is. And the standard arm, patients in standard arm do very poorly, or poorer than what you expect. The difference that you see in the experimental arm may actually not be what it does. The CalGB A0101 trial, the intensification of chemotherapy schedule alongside chemotherapy, interestingly, did not improve survival in adjuvant setting compared to chemotherapy alone. So, adjuvant chemotherapy versus adjuvant chemotherapy, there are trials that have looked into this. The ARTIST-2 and the Dutch critics trial. Meta-analysis of all of them have shown that higher rates of disease-free survival and reduced local regional occurrences with chemoradiation. But the overall survival benefit there's a trend that favors chemoradiation, but it's not significant as of yet. It's just a picture showing the chemotherapy, different techniques for chemotherapy for stomach cancers with a simple two-field conformal radiotherapy where you have two fields treating the remaining stomach or rest of the stomach. This is a 5-field technique with 5 fields of radiotherapy, which is much more conformal, try and spare side effects to the critical organs. an IMRT treatment where the treatment is much more conformal, and you can spare MBChB dose, for example, to liver, in the spinal cord. This is the NCCN guidelines on surgical outcomes of patients who had a upfront surgery and have not had any chemotherapy. So if they've had an R0 resection, if they have T1 or not, or intravitreal carcinoma, they can just undergo surveillance, which is reasonable and sensible. For those who have PT2 and are not, if they're not particularly fit, surveillance alone will suffice. But if they have other high-risk features alongside the staging, and for example, if they had a poorly differentiated cancer, or they had vascular invasion, or they did not undergo a D2 resection, then they want to offer chemotherapy alone, or even chemotherapy plus chemoradiation as per the NCCN guidelines. For those who got T3, T4, any, and if it's M0 or any T, but positive nodes, you want to consider adjuvant chemotherapy and add chemotherapy in if they had less than a D2 resection. You only offer chemotherapy alone if they've undergone a primary D2 resection. And sensibly, you'd offer chemoradiation if they've had an R1 or an R2 resection. And obviously, the case is somewhat different for those with metastatic disease. For summary, for resectable gastric cancers, i.e. T2 and 0 and above, we would want to offer upfront neoadjuvant chemotherapy followed by surgery, followed by more adjuvant chemotherapy, otherwise what we would describe as a perioperative approach. However, for patients who've already undergone a primary surgery, should be offered adjuvant chemotherapy after. If it's a P2 and not, they can undergo surveillance below. But we want to consider adjuvant chemotherapy if other high-risk factors are present, including the possibility of chemoradiation if they've had less than a D2 resection. For PT3 or 4 or M1 disease and beyond, chemotherapy plus minus chemoradiation, I would say, particularly if you've not had a D2 resection. What would you do for unresectable disease? So M0 meaning you don't have any evidence of distant metastases, but you've got a very locally advanced T4 and 3 disease. There's no randomized trials, however, for upfront chemotherapy plus minus chemotherapy to show that this would enable such patients to undergo a potentially D2 resection. But preliminary data, based on retrospective historical data, would suggest that this may be possible in up to 70% of patients who were thought to have unresectable disease initially. PCR rates have been reported of up to 30%, but these patients have been carefully selected, and this highlights the importance of having a very good functioning MBT or medicine team, where you have an experienced surgeon, an experienced oncologist, radiologist, and pathologist all on board discussing the case for patients where even if they have unresectable disease, that not all the hope is lost. It depends on how fit the patient is and the patient's acceptance of risk. We'll probably offer them neoadjuvant treatment with systemic chemotherapy, as mentioned earlier, and then maybe even preoperative chemotherapy in this instance. And then some of them can be downstaged, or the disease can be downstaged to a point that you may be able to have a clinical resection. But we don't have a trial to prove that, oh, this will lead to better survival benefit, but there's data that it may be the case. For patients with metastatic disease, M1 classification, that means they've got distant metastases. Obviously, the mainstay of treatment now will be surgery, will be systemic treatment, and that would involve usually cytotoxic chemotherapy, plus minus a targeted agent, depending on biomarker analysis, and plus minus immunotherapy, which has now become the newer in vogue treatment for most cancers in the metastatic setting. The aim is to palliate symptoms, improve quality of life, and prolong survival. And as mentioned briefly, choice of first-line therapy and what we offer patients will nowadays depend on the biomarker assessment. And that, which I mean, a biomarker assessment would include the assessment of the HER2 status of cancer, whether patients have a deficiency in mismatched repair proteins, or if they've got microsatellite high disease, and the overexpression of the PD-L1. For HER2 positive gastric adenocarcinomas, so if you only have the biomarker analysis and patients have HER2 positive disease, i.e. IHC3 plus or FISH2 plus and above, the addition of trastuzumab to standard platinum-based backbone chemotherapy increases the response rates. from 35% with standard chemotherapy alone to 47%. The modest increase in median survival. And we've seen that with the phase 3 PROGRA trial, where they use this cisplatin protein in backbone. But in practice, for clinicians, they tend to use other regimens, which is a bit more logistically easier to offer. For example, K-box chemotherapy or FOLFOX chemotherapy. In the Keynote 811 trial, pembrolizumab was added to trastuzumab and a plasmid-based chemotherapy backbone. And in interim analysis, overall response is higher with the pembrolizumab, or 74% versus 52%, with a longer median duration of response and ongoing response at 6 months onwards. So nowadays, for patients who are fairly fit, even if you are HER2-positive disease, we want to add pembrolizumab, regardless of PD-L1 expression, as we may have a high overall response rate. Now, frontline immunotherapy with reductive chemotherapy is a good option for patients with tumors expressing high levels of PD-L1 with a CPS score of 5 and above. Monotherapy with immunotherapy with pembrolizumab can be considered a patient with a CPS score of 10 and above with non-bulky disease, as demonstrated in the Keynote 062 trial. Nivolumab is another immunotherapy drug can also combine with chemotherapy, demonstrating better median survival than chemotherapy alone. And the benefits always seem to be more pertinent in patients with CPS of 5 and above, as demonstrated in the CheckMate 649 trial. In patients with low PD-L1 expression, chemotherapy will still be used in combination with chemotherapy, particularly if a deficiency in MR or MSI high is present. Analysis of patients with deficiency in MR or MSI high, in addition to CPS score above 1, from the Keynote trials have shown that combined therapy with FRCR can provide a more significant benefit of survival and higher objective response rates when compared to chemotherapy alone. Even immunotherapy, monotherapy might actually provides a higher longer survival when compared to chemotherapy alone for these group of patients with a deficiency in MMR. Now, for any reason, a patient not caring for immunotherapy or trastuzumab, for example, patients with existing autoimmune disease, or patients who already have immunosuppressants, or who had organ transplant, for example, or patients with a degree or moderate degree of heart failure where they can't have Herceptin or trastuzumab, you can still have systemic chemotherapy alone. And again, the choice regimen will depend on the patient's fitness, preference, existing medications, morbidities, etc. The examples include combination chemotherapy regimens such as K-POX or FOLFOX, as I mentioned earlier, in the neoadjuvant setting, ECF triplet combination, again, similar to what we use in the neoadjuvant setting, cisplatin and fluoropyrimidine, or cisplatin plus S1. And for patients who are not particularly fit with a borderline performance status, for example, performance status 2, the range of performance status 3, you might want to consider monotherapy as just using a single agent treatment with a 5-FU or fluoropyrimidine class drug, capecitabine, or indeed S1. That ends my talk. So hopefully I'm not being bored by my talk, but hopefully I've been able to share with you sort of an overview of gastric cancer and where we are right now in terms of treatment.
So thank you so much, Doc. I think that was a very comprehensive kind of overview of quite a lot of the areas pertaining to gastric cancer. Doc, I think you were saying earlier to us as well, in terms of diagnostic stages in Malaysia, are we still looking at a lot of those diagnoses being in later stages of disease?
Yes, from what I've gathered so far, based on my discussion with colleagues, yes, patients tend to come to clinic, they tend to have a later stage, because have a later stage of disease, i.e. stage 3 or stage 4 when they're symptoms. So it's interesting to know that patients in countries where the incidence is quite high, there's an initiative there where if these patients can come earlier, they can be cured. I mean, in the early gastric cancer, you look at 90% survival rates in Japan, which is really remarkable. So in Malaysia, there's still the notion that if you've got stage 3, stage 4, it's a death sentence. And that's actually true for a lot of other cancers as well, the same notion, but it's not always the case. So patients even with stage 3 disease, if they have had good downstaging, even if they have unresectable disease, again, the definition of unresectability is very much MDT dependent.
Mm.
So it's not just sort of a point of view of one particular physician or surgeon. It's very unlikely that if you've got an experienced surgeon that his or her view will be not shared with other surgeons. Probably will be the same. But it's important that's made in an MBT scenario. So I think that's very important. So the development and evolution of MBT in cancer practice in Malaysia needs to improve, and also screening for high groups, for those who are at high risk of developing gastric cancer. If they have a strong family history of gastric cancers or other malignancies, but it's suggestion they have a Lynch syndrome, for example. Yes, this patient should be targeted and they should be counseled about having earlier gastric screening opportunities, including using upper GI and NOSA.
Okay. Lovely, Doc. We've got quite a significant number of questions running both on Facebook and some of our closed WhatsApp groups, as well as on Docity as well. For our colleagues who are following the session live, please feel free to kind of drop your questions, and Dr. Abel will be very happy to kind of field them. Of course, we're just a bit cognizant of Doc's time as well, that he's taken time off his busy schedule today on a Saturday, kind of speak to us. Doc, couple of questions, some of it coming up are, what percentage of gastric cancer patients are actually concomitantly H. pylori positive?
Quite a number. So if you in my slide earlier, I did mention that serologically, in Malaysia, for example, up to 70 to 80% of them will have positive H. pylori antibodies in the bloodstream for those who've got gastric cancer. So it's quite common. And it's probably one of the most common causes of gastric cancers. Right. So that leads to the suggestion that maybe we can eradicate H. pylori, maybe we can prevent developing gastric cancers. But it's difficult going around offering everybody H. pylori eradication. Such. In Korea, if I'm not mistaken, there was a study that looked into offering patients who had high risk of developing gastric cancers, either because of family history. If they had H. pylori, documented H. pylori, they would give them H. pylori eradication and they would monitor and see whether they develop gastric cancer later on. And actually, the incidence of gastric cancers in patients who have H. pylori eradication, for those who had higher risk of developing gastric cancers, did drop almost by half. So yes, there's a role for H. pylori eradication, particularly for patients who have got a history of strong family history of gastric cancers. And for patients who have GORD or gastric esophageal reflux disease, their endoscopy quite routinely, if I'm not mistaken, most gastroenterologists or surgeons would do an H. pylori test. And if you've got evidence of gastritis, frequently patients will be offered an eradication program.
Okay. And contextualizing, Doc, into our local kind of landscape, we have now, of course, this coming up on the end of the year, and then everybody's got these kind of nowadays, which is a good habit. We kind of go for our medical checkup towards the end of the year, and very often nowadays you offer your urea breath test, or what is this, some kind of test which detects H. pylori even within the kind of primary care setting. The question is, Doc, and one of our colleagues asked this, I keep on doing eradication for the patient, and do I retest because the patient seems to be in the subsequent year coming back positive as well?
Yeah, I think if there must be a reason why they've done the testing, in the sense that it's not just about screening, but I think about symptoms. I think if you've done the eradication program and you still have ongoing gastritis symptoms, I think it's probably important in that instance to maybe refer to a gastroenterologist, specialist, to see whether an endoscopy will be required. Because the symptoms may not just be purely related to H. pylori infection itself, it's the ongoing issues of gastritis. So if the pathology has set itself and then the chronic gastritis is already taking place, it's already established, then even if you eradicate H. pylori, doesn't automatically revert. So if it's already gone into, if they've already developed chronic atrophic gastritis, that can lead on to the development of cancer later life. So even if they've eradicated H. pylori or they've given an effective treatment, it still not be positive, in particular the symptoms are positive, they still have ongoing GORD, because that would explain why they're coming back to see you, I would imagine. That if you've got symptoms, rather than relying on PPIs, or DHT antagonists, I think you should probably refer those patients on. And more alarmingly, if they've got evidence of iron deficiency anemia, or if they've got weight loss, or any other features, that will be what we call reflex SANS, where they will require upper GI endoscopy sooner later.
Right, absolutely. Doc, there's also a question on whether there is a correlation to kind of people having colorectal cancer and gastric cancers? Is there kind of a relationship in terms of heredity?
Very good question. The Lynch syndrome patients, yes, there's high risk. And for patients with familial adenomatosis and FAP disease, they have polyps throughout the gastrointestinal tract. So those polyps have the risk of transforming into a cancer. So such patients are at risk of both stomach cancers, colorectal cancer, even intestinal cancers. So yes, in the hereditary patients, in the hereditary familial cancers, yes, there is a link for gastric and colorectal cancers, particularly these two syndromes, the Lynch syndrome and FAP. But de novo colorectal cancer or de novo stomach, just a patient turning out with stomach cancer with no other history as such, that doesn't mean that because they've got stomach cancer and with no other strong history or risk factor, they will then go on to develop colorectal cancer. Frequently, patients who have had the colorectal cancer or gastric cancer end up usually having a top and tail investigation. They have an RPGI as well as at least a sigmoidoscopy or coloscopy as part of their investigation for nioplasia anemia. So they had that and they find polyps, incidental polyps in the colon, for example, and they then get surveyed and followed up.
Right. Thanks, Doc. And this is, I think, a very kind of new question, Doc. So one of our colleagues asked, nowadays quite a lot of our patients are going for a gastric bypass surgery for cosmetic and weight loss reasons. Do any of these surgeries kind of predispose them to having gastric cancer?
Good question. If I'm not mistaken, having a surgery, build off surgeries, I mean, there may be an increased risk for gastric cancers because of the not exactly certain as to the reason, but apparently patients who have previous surgeries can have gastric surgeries or maybe at risk of gastric cancer for the remaining stomach. So yes, there is that possibility. And even patients who had abdominal irradiation for other cancers in the past, they have increased risk of secondary cancer. So nowadays, when we give, for example, when we give breast radiotherapy, you'll notice that some of the radiotherapy actually passes through the stomach lining. So we do warn patients that radiotherapy breast cancer may predispose them to secondary cancer in the future. The risk is small, but it's there, and particularly they might be surprised if they were to say stomach cancer years later, and it may actually be related to radiation. But coming to the question, yes, if I'm not mistaken, since surgery in the stomach, yes, we've noted increased risk of developing primary gastric cancers as a result.
Right. Doc, this is, I think, more so a comment than a question. And I think the colleague kind of asks us for your comment on this. So it says treatment with surgery alone offers a high rate of failure. Chemotherapy and radiotherapy have not improved survival rates when utilized as single modalities, but combined therapy has shown some promise. And I think you've been showing us quite a bit of data on that, right, Doc, throughout the latter part of the discussion today. Any comments for you to perhaps add to this?
Yeah, sure. It's a great comment. Definitely, and that's why combined modality is very important. So you should not have a gung-ho surgeon who just does do surgery alone and feels, okay, we don't need to get more beyond that. No, I think you need to discuss that in MBT and to have a joint consensus about when we come up to formulating a management plan for the patient, because that will offer the best survival for the patient. Having said that, if you look at the Japanese trial and the Korean trials, a lot of the patients that even with no possible disease do very well, relatively speaking, compared to the Western patients. So that's still a bit of a conundrum as to why it happened. Why are Japanese or East Asian patients doing better stage for stage? Is it to do with the biology of the disease? Is it to do with the particular molecular characteristic of the disease? Is it a surgical expertise? Is it because they do quite a number of surgical procedures for these patients, and therefore they become very accustomed to removing the disease and therefore reducing the mortality rates, significantly perioperative mortality rates, and therefore you see an apparent increase in survival. So if you look at the MAGIC trial, for example, I showed earlier, the survival at 5 years for surgery was 22%, but about over 60% for patients in the Japanese trial, which is quite remarkable. It's almost threefold. So if you look at the Japanese, if you go to Japan, I think they will say to you, gastric cancer is not a death sentence. They're fairly confident about the figures, and they can prove it, they back it up, and we know that in through publications. So yeah, I think the specialist, where you undergo the treatment is very important. Root cause, the surgeon, It's very important. So as a patient, if there's a patient out there considering the options, it's very important to go to a center, a high volume center, where they've got data to back up. They can do a good uterine resection, low operative mortality rates. You don't want to see operative mortality rates of 13% in one of the trials that we saw earlier. That's quite significant. It means more than 1 in 10 of these patients who have surgery will die as a result of having surgery. So just goes to show how morbid surgery is. But you get rates of less than 1% in Japan.
Right.
That's pretty impressive. So that's with a D2 resection. And D3 resections, if you look at a trial like compared D2 versus D3, they have mortality rates of less than 1%. I thought it was really remarkable. They are able to do something that we haven't gone to Japan. I haven't seen how they do things. I think it's very remarkable when it comes to the management of stomach cancers. But yes, multimodality approach though is important. But surgeons in Japan prove that the surgery component is extremely important, and the additional gains you have with adjuvant chemotherapy adds on to that. But the surgery, wow, very important. The additional gain you get is significant. Whereas if you look at MAGIC trial, 23 versus 32%, the extra benefit you get with adjuvant chemotherapy is significant. But if you look at absolute numbers, they're not very big.
Absolutely. Doc, also, I think I just want to draw like a little bit of a kind of focus back to what you were saying earlier about the kind of use of MDTs. And so your center is a center in which you have like an MDT system going.
We should announce that. No, we don't actually have one.
But is there like an informal?
Yes, we have an informal meeting. But this is something I'm trying to, or will hope to establish if I can. Had some sort of informal CME discussions about organizing an MDT, because I think it's good for the patient to know that their case is discussed, and not just with yourself, but with other colleagues as well. And then they know that you're at least getting a consensus approach. And if there is one thing that I believe is the best treatment alone, or how good the treatment options sound in clinic, that really makes a big difference. In the long term, it's the MDT, and the decisions that come out from that is what, in my opinion, at least, makes a big change or makes a big difference. Because a patient who had, say, primary surgery followed by chemo, will do okay, but if they've had neoadjuvant chemo or perioperative chemotherapy followed by surgery, or with surgery and chemo after, maybe even better. So if that had gone through an MDT, little gains from each patient will add up quite a bit in your overall,
in the overall kind of long-term prognosis. Yeah,
that's fine. So the establishment of something as informal or formal MDT can make a big difference to a patient's survival outcome. When we used to go for MDTs in the UK, we used to find, I'm just being honest here, we find a bit of a bore because you have to go through a lot of cases. You usually have squeezing time in between clinics, during your lunch hour. You don't even have lunch sometimes because you've got 20, 30 cases to go through. I begin to miss them now because I realized that when you're in that MDT, you start to not just appreciate about what others can do, but you also gain some expertise because you now start to understand what the surgeon is talking about. When he says or she says, I can't do this, or this is why I think it's unresectable. Whereas if you have a patient that's gone through a surgery, you haven't discussed it, and you have not sort of combined his or her opinion with that of the radiologist in front of you, you can't appreciate as much. As an MD, you see that. You sort of see a flow of those investigations, as opposed to seeing it on a computer or reading it in a piece of paper.
Right, absolutely.
So the flow is very important. So I think there's one thing we can do. I think in some private hospitals like Pantai, for example, they do have MDT running. So I think it should be there should be a national incentive behind establishing MDT in any cancer center in Malaysia. It's good practice, and there's evidence to back it up that it can actually improve some of just clinical trials. Centers which have more clinical trials seem to show that it actually got better outcome because of better quality control.
Absolutely. Absolutely. And Doc, so there's another question, and I think again this is kind of repetitive. I think this is something you already kind of went over, but perhaps just to kind of stress the point again on the role of targeted therapy, immunotherapy within treatment of gastric cancers. I think Doc showed us quite a bit of data pertaining to that, including from Keynote with Pembro. But maybe Doc, you can comment on how it's changed the landscape, perhaps, in treatment of advanced cancers.
Absolutely. So by having immunotherapy on board, I mean, it just adds another option of treatment for patients. So in a metastatic setting, some patients can have ongoing complete responses, but it's for the select few, not everybody. And data out there seems to suggest that those who have a higher TPS or what we call CPS score, a 10% and above, are the ones who benefit the most. For patients with HER2 positive disease, we certainly want to consider adding a trastuzumab earlier on, and those who can tolerate and potentially afford chemotherapy in addition could then add chemotherapy as well, for example, pembrolizumab in the first line setting. And for patients who are not particularly fit or those who you have concerns about giving chemotherapy, you may even want to consider offering chemotherapy monotherapy just on its own. If they've got low bulky disease, for example, they've got just 2 or 3 small liver metastases, or a few lung metastases, few nodal disease, they're not at risk of developing liver failure or organ dysfunction. You may want to consider immunotherapy for them, particularly if the CPS score is more than 10%, because there's a good chance of response. And particularly if they've got a high MSI or deficiency in MMR, they tend to be even better. And they tend to express PD-L1 more so as well for those who have deficiency in MMR.
Right. And I've always kind of asked this question of all our guests, perhaps to kind of also stress the kind of necessity, I think, more so nowadays for, immunohistochemistry to be done, and how our colleagues should actually also help to convince their patients on the kind of importance of getting this done. Doc, some thoughts on that?
So molecular analysis, because in private sector, you have to pay for additional molecular tests. But we have to explain to the patients why we would like to do that, because we will potentially change management, unless, of course, cost becomes a significant issue and financial burden to the patient, where even if, let's say, they will find it's possible that they can't afford the addition of targeted agents. Unfortunately, a lot of targeted agents and immunotherapy drugs are expensive. And although there's assistance programs generated by the pharmaceutical companies, but it is still priced quite expensive. And I would imagine, correct me if I'm wrong, but patients don't have that access to that even in the government sector. So it's going to be difficult for some patients to have direct access to these drugs, particularly when the cost is an issue. But as long as the cost can, financial burden is not so much of an issue, then obviously we should discuss molecular testing for patients. And in the future, the paradigm is shifting more towards doing personalized medicine, where it won't just be the 3 things I was talking about, the DMMR and PD-L1 and HER2, but the other CDH31 and all kinds of genetic molecular tests to be done in the future, as is happening now with lung cancer. You're seeing all kinds of biomolecular analysis, and that's changing the whole landscape of lung cancer treatment. And so much so that patients are nowadays having repeat biopsies at every point of progression just to see if they developed another mutation that allows them to have another drug. So I suspect same will occur for most cancers in any site. So that's the evolving landscape. We're seeing patients having more biomarker or molecularly directed therapy. So it's not like just a blunt and bust approach, not a general domestos that we used to give with chemotherapy, where you just give chemotherapy and detect everything that's in the way. We are becoming more targeted nowadays. So immunotherapy is one example of that. But immunotherapy is not actually targeted therapy. I mean, targeted therapy like trastuzumab is an example of that. The immunotherapy is actually not a treatment that directly attacks cancer. It's actually trying to waken up or revive, if you will, your own immune system, your white cells to attack, to recognize the cancer cells as enemies and to attack them. So it's aid and assist that. So it's a very noble, very intelligent drug. But the white cells that they get awakened and they can see the cancer cells, they tend to get a bit paranoid sometimes, and they can end up attacking other parts of the body. Right. And that's what can cause a whole lot of issues as well. So.
Okay, so Doc, thank you so much for taking, I think, this quite a large number of questions, and I'm also kind of cognizant that we're over the hour quite a bit, entering into the second half of the hour already. So I'm going to kind of see if there's other questions going on, and if there are none, Doc, maybe if I could kindly ask you to leave us with some, take-home important points that can be at the top of our heads as we close up the session.
Yeah, sure. So take-home points, if you have a strong family history of gastric cancers, possibly also even colorectal cancers or malignancies of the GI tract, or if you have a strong family history of breast cancers, ovarian cancers, and you're worried, particularly if you've got strong family history of cancers that have occurred earlier than 50 years of age, particularly family members involved is less than 50 years of age and quite a number of them, I think you should consider having some form of screening. And what the screening involves would involve or would have to take into consideration gender and age in question. But if you've got symptoms of iron deficiency anemia and it's unexplained, for example, a lady who doesn't have any heavy periods, iron deficiency anemia, or even pernicious anemia where you've got B12 deficiency, then I think you must undergo some form of screening, at least for H. pylori screening. The H. pylori screening is just the infection. It doesn't, you don't probably should have an endoscopy view as well of the stomach, in my opinion, and even of the esophagus, because we're seeing increasing incidence of gastric GORD disease, which may in part increase the risk for upper GI malignancies, particularly in the gastric tract. And therefore, you should have endoscopies. And patients will have, say, if you've got metaclastic changes indicative of Barrett's dysplasia in the lower esophagus, they should undergo surveillance a yearly or a 2-year basis to ensure that they don't go on to develop cancers, for example. So if you caught it early, then patients can be cured of the cancer. And like the Japanese have shown, if a patient has been detected to have early gastric cancer, they can have an amazing survival rate by having even endoscopy mucosal resections alone, even without morbid gastrectomy. So that's very impressive. So if you're a smoker, stop smoking. Stop eating all very salty. It's tasty, but all the salty foods, sausage, ham, bacon. Reduce your red meat consumption. Eat more fruits and veg. That's a protective influence. And maintain a healthy lifestyle. Even if you're a cancer survivor, some patients who've had cancer will say, well, what's the point? Still got cancer. But the point is, if you're a cancer survivor, the healthier you are, the stronger you are, the more likely, touch wood, but more likely if cancer was to recur, you'd be better placed to undergo any further treatment that can still potentially cure it, if the fitter you are. Because a lot of factors that affect our ability to deliver a treatment is the patient factor.
Right.
So whether the patient is fit enough or strong enough to undergo treatment. A lot of patients I've seen in Malaysia have the famous 3 cohort: diabetes, hypertension, and cholesterol. Even before they mention it, have you got these 3? So I think it's important to have a very good lifestyle, a healthy lifestyle, and we should address these 3 big morbidities in Malaysia. Because I think if you can stop smoking, reduce smoking, because I think there's an initiative or big thought about stopping smoking for patients, for people who are born after a particular year in Malaysia, which I think is a very commendable effort. Everybody will agree with that. I think it's a very good thing. If you can stop smoking, you can reduce a lot of cancers, not just stomach cancer. And maintaining a healthy diet, having a good diet, and a healthy lifestyle, maintaining weight, obesity, can actually increase risk for cancers as well. So avoid diabetes at all costs. Avoid hypertension at all costs. Some people say that, oh, if you got it, never mind, you can take a tablet. It's not just the tablet. You've got side effects of the tablets to deal with.
Yeah.
So be healthy, be strong, live a good life, enjoy life stress-free. Easier said than done, I guess. But that's the main take-home message. If you got H. pylori infection, yes, do eradicate it. Do undergo an eradication program, and if there's a health screening program nearby, we can do the urea stays test. And if you're worried, particularly if you've got GORD symptoms or gastritis-like symptoms, and you've got anemia, I think certainly you should undergo the screening test, and at least potentially may even be on to having an endoscopy. But whatever you do, make sure you see a well-qualified either gastroenterologist or a surgeon. Can do a proper endoscopic assessment. I'm sure there are many specialists out there who can do all this for you. And hopefully you never have to come to see us as an oncologist, because ultimately we are here ultimately for one goal, which is to prevent it and avoid cancer at all costs. We're here as oncologists, we're here to treat cancer. But it would be better if they never have cancer in the first place. So prevention is always better than cure.
Absolutely. And on those words, let's draw this session to a close. Doc, thank you so much for joining us this morning and giving us all these really important and relevant points. Ladies and gentlemen who joined us this morning as well, thank you so much for joining us on this series of SKD on gastric cancer. And speaking to us today was Dr. Abel Zachariah, consultant clinical oncologist from Hospital Pantai, Keroh, Malacca. So thank you so much. And of course, you can review and revisit at any time this session on Docity. So, and have a wonderful, wonderful weekend. And we'll see you soon.
Thank you, everyone.